Om Swastiastu. Hello everyone, my name is Huliana Lim. I am the representative of Student Group Discussion B8 Udayana Medical School. In this occasion, we will present our student project of this visual blog with the given topic, Artery and Vein Retinal Occlusion. Next, this is our group members, and the presentation will be continued by my peers. Thank you.
Thank you for the opportunity. My name is Krishna Putra Pramanda with student number 128. So now I would like to start this presentation with a background. Retinal vascular occlusion is a vascular disease that is often found in patients with reduced vision and can occur in both veins and arteries. And it's called central retinal artery occlusion or CRAO and central retinal vein occlusion or CRVO. Epidemiologically, CRAO is quite rare and increased with age, as well as CRVO, which is one of the leading adults to have abrupt painless eyesight loss. And then the risk factor, there are so many risk factors of CRAO, include ipsilateral carotid artery stenosis, cardiac illness, and previously undiscovered vascular disease. Meanwhile, the risk factor of CRVO is open-angle glaucoma, systemic hypertension, and diabetes. The pathophysiology of CRAO is artery blockage originates in the choroidal circulation, which perfuse the outer retina, while the pathogenesis CRVO is triggered by an increased factor that contributes to thrombosis. And then the clinical manifestation in patients with CRAO and CRVO tend to be almost the same, including blurred vision or sudden and massive loss of vision. And then the treatment, the first absolutely necessary step in CRAO and CRVO management is to figure out which classification of CRAO and CRVO one is coping with. With the increasing prevalence of morbidity and mortality and symptoms if not treated, further and better understanding of artery and vein retinal occlusion will be very useful for us as medical students or maybe a doctor. So now I would like to tell you about the research question. The first one, what is the definition of artery and vein retinal occlusion? What is epidemiology of artery and vein retinal occlusion? How is the classification of artery and vein retinal occlusion? What are the risk factors of artery and vein retinal occlusion? How is the pathogenesis of artery and vein retinal occlusion? What are the clinical manifestations of artery and vein retinal occlusion? How to diagnose artery and vein retinal occlusion? And then the last one, how is the treatment available for patients with artery and vein retinal occlusion? So now I would like to tell you about the objective. The first one, to understand the definition of artery and vein retinal occlusion, to know the epidemiology, classification, the risk factor, the pathogenesis, the clinical manifestation about the artery and vein retinal occlusion, and to how to diagnose artery and vein retinal occlusion, and to find out the right treatment available for artery and vein retinal occlusion patients. And now I would like to tell you about the benefits for medical students to complete knowledge of artery and vein retinal occlusion, for scientific learning to learn about artery and vein retinal occlusion and know how to treat it, and for a community to increase knowledge in the community who have a better understanding of artery and vein retinal occlusion and the appropriate therapy for it. I think that's all from me. This presentation will be continued by my friend. Thank you.
Hello everyone, my name is Natasya Pusparani with the digit number of 227, and here I'll be explaining about the definition of artery and vein retinal occlusion. Firstly, the artery retinal occlusion or the central retinal artery occlusion or CRAO is an instant obstruction of the central retinal artery, which can cause retinal hyperperfusion, gradual damage of cellular, and loss of vision. The degree of severity and duration of retinal ischemia will determine retinal survival. As for the vein retinal occlusion, this is the blockage of the retina's venous drainage system. It can be done by two ways, the central retinal vein occlusion or CRVO, or by the branch retinal occlusion or the BRVO. CRVO is the blockage of the central retinal vein, which is located posterior to the lamina cerebrosa of the optic nerve. It is further divided into two categories, non-ischemic and ischemic. As for the BRVO, it is a blockage of one of the central retinal veins branches at an arteriovenous crossing.
My name is Gede Samudra, number 023. Now I will explain to you about the epidemiology. RVO or retinal vein occlusion is the second most frequent retinal vascular condition after diabetic retinopathy. In 2008, 16.4 million adults aged 30 and up were diagnosed with RVO, with 30.9 million having PRVO and 2.5 million with CRVO, according to their calculations. CRAO was 1.4 times more common in men than in women per 1,000 or 100,000 person years, respectively. In most age groups, men outnumber women. RVO has been linked to advanced age, hypertension, and other vascular variables in previous research. Non-arterial CRAO or NACRAO, transient NACRAO, NACRAO with cilioretinal artery sparing, and arterial CRAO are the four clinical entities that form CRAO. That's all from me. Thank you.
Hello, my name is Azza Alfadhila with registered number 094. I will explain about the classification of artery retinal occlusion. Artery retinal occlusion can be classified into two types: central retinal artery occlusion or CRAO and branch retinal artery occlusion or BRAO. CRAO occurs when a blockage forms in the central retinal artery, with embolus being the most common cause. It causes sudden painless unilateral vision loss. CRAO can be caused by three forms of embolism: cholesterol, calcium, and platelet fibrin. Meanwhile, if the blockage occurs in a branch of the central retinal artery, the abnormality is known as BRAO. The most common cause of BRAO are the same as for CRAO. It be cause of cholesterol or fibrin embolus. This disorder can cause vision loss due to retinal tissue hypoperfusion. BRAO can further classify into permanent and temporary BRAO. The permanent BRAO will result in more severe vision loss and worse visual prognosis. That's all from me. Thank you.
Hello everyone, my name is Bagus with my number is 2202-51184. So today we'll talk about the classification of vein retinal occlusion. So as we know that in the retinal vein occlusion or RVO has the different types that we can classify. In the previous research, based on the affected retinal surface, retinal vein occlusions can be classified into three types. The first one is central retinal vein occlusions, the second one is hemicentral retinal vein occlusions, and the last one is branch retinal vein occlusions. But in the latest research, there are only two that are approved. There are BRVO and CRVO. Talk about the CRVO is it occurs in the central retinal vein posterior to the laminar fibrosis of the optic nerve, with the thrombosis being the most prevalent causes. If only 1/3 of the retinal surface is affected, the condition known as the RHCVO or hemicentral retinal vein occlusions. In the BRVO side, the blockage occurs in the one of the central retinal vein branches. CRVO and HRCVO are further subdivided into non-ischemic and also the ischemic types. The most common types of CRVO is non-ischemic CRVO, which contributes for approximately 70% of all cases. On the other hand, BRVO is divided into a major BRVO and a macular BRVO.
Hello everyone, my name is Angelyne from Mulia with last three digit numbers 051. So next I will explain about the risk factors of artery retinal occlusion. The risk factors of CRAO or central retinal artery occlusion are often associated with age, sex, and certain systemic comorbidities. Older age, especially more than 50 years old, and male patients have higher risk factors for CRAO. The systemic comorbidities are often related to vascular risk factors, and the most common risk factors are hypertension, hyperlipidemia, carotid stenosis, atherosclerosis, diabetes mellitus, tobacco use, cardiac valvular disease, history of cerebral stroke, sickle cell disease, migraine, and aortic disease or aneurysm. Furthermore, some comorbidities that increase the risk of CRAO significantly are systemic vasculitis, carotid stenosis, glaucoma, hypercoagulable state, syphilis, cardiac valve disease, migraine, and hypertension. That's all from me. Thank you.
Morning, doctor. My name is Nga Xhi Wei, with the NEET 150. So today I'll be explaining the risk factor of vein retinal occlusion. So risk factors of vein retinal occlusion include smoking, systemic diseases like hypertension, diabetes mellitus, dyslipidemia, and also a history of angina, and cardiovascular diseases, history of glaucoma, especially open-angle glaucoma, macular edema, foveal ischemia, secondary vitreous hemorrhage, loss of retinal membrane formation, subretinal fibrosis, retinal arteriolar macroaneurysm, and also traditional retinal detachment. Thank you.
Hello everybody, my name is Putra and my student identification number is 2002-5110N4. So in this opportunity, I want to explain the pathogenesis of artery and vein retinal occlusion. The first is artery retinal occlusion pathogenesis. Similar to cerebral infarction, retinal artery occlusion results from acute interruption of blood flow to the eye from the first underlying condition. Emboli from the internal carotid artery, aortic arch, or heart are the main cases of retinal artery occlusion. Data have now shown that cardiac emboli, especially related to atrial fibrillation, are a major cause of acute retinal artery occlusion. Okay, the next is pathogenesis of RVO or retinal vein occlusion. The pathogenesis of RVO is multifactorial. Arteriosclerosis strongly contributes to the onset of RVO. Arteriosclerosis results in vein occlusion through endothelial cell damage and thrombosis. For instance, a rigid artery compressed the underlying venous wall at the arteriovenous crossing, resulting in disturbance of venous return and change in the course of its flow, turbulent blood flow, chronic damage to the retinal vascular endothelial cell, and thrombosis formation will result in onset of RVO. Another hypothesis is that arteriosclerosis result in arterial insufficiency leading to RVO. Okay, that's all the pathogenesis of artery and vein retinal occlusion. The presentation will be continued with my other friends. Thank you.
Hello friends, my name is Felix, the GD of student ID journal, and I will continue the presentation regarding the clinical manifestation. So, in a patient of artery occlusion and vein occlusion has almost the same of symptoms, which are blurred vision and massive loss of vision. However, there are some distinct features which can be found in each type. So first, regarding the retinal vein occlusion, it can be asymptomatic or symptomatic with a sudden painless disturbance of reduced vision. The visual impairment in retinal vein occlusion are not prominent and rapidly as in arterial occlusion. The vision loss are dependent during the day and more prominent during the morning. Other than that, there is a clinical findings such as flame-shaped hemorrhage, which can be found in the whole area of intraretinal area. Other than that, there also found swelling in optic nerves, damage at retinal nerve layer, and cottonwool spots. And also, patient has a normal result in the eye exam. Other than that, next regarding the artery occlusion. So the artery occlusion are found which are a sudden and painless vision on monocular of the eye, and the vision loss are more observed during the day and the first half. After pupillary reflex and monocular loss of perception are also found in the artery occlusion. In eye examination, patient also shown a normal research from the intraocular and the anterior chamber and also extraocular eye movement. There's also a typical feature can be observed, which are cherry red spot macula. Next.
Thank you. Hello everyone, my name is Huliana Lim. My student ID number is 2002511080. Now I will continue the presentation with the diagnosis of artery and vein retinal occlusion. First, I will start with the diagnosis of artery retinal occlusion. This diagnosis is clinical based and supported by laboratory examination. Artery retinal occlusion characterized by painless visual loss, including reduced visual acuity and pupillary defect. To help determine the diagnosis, we can do eye examination such as fundoscopy. In this fundoscopy examination, we can find the sign of the occlusion, which is cherry red spots, dilatation of retinal vein, hemorrhage, and edema. Also, we can do fluorescein angiography or FA to determine the prognosis of this diagnosis with appearance of residual retinal. We can do the initial lab such as glucose test to help determine the diagnosis. Also, complete blood count and coagulation assays. Other diagnostic tests that might be considered depending on patient risk factor and medical history, such as CT scan, lipid profile, and electrocardiogram. Okay, now we will continue with the vein retinal occlusion. Basically, is the same. The diagnosis is made by clinical observation of the eye and supported by laboratory examination. Patient with central retinal vein occlusion or CRVO experience a quick and painless loss of eyesight. And to determine the diagnosis, we can see from the fundoscopy there are cotton wool exudate, venous dilatation, and tortuosity. Also following with the flame-shaped retinal hemorrhage and retinal edema. The most common imaging modality in retinal vein occlusion is optical coherence tomography or OCT, which can be used to detect characteristics such as macular edema. Also, we can do a FA examination or fluorescein angiography to observe the peripheral capillary non-perfusion, also macular ischemic and neovascularization. Another test that can be done to determine the etiology of CRVO, which is related to vascular disease, such as blood pressure, CBC, blood glucose, and electrocardiogram. Okay, I think that's it for the diagnosis. We can continue with my peers. Thank you.
Good afternoon, doctor. I would like to continue the presentation on treatment of central retinal artery occlusion. I'm Annisa Nuraini with the last 3 digits of NIM 110. So, pharmacological treatment in central retinal artery occlusion has limited efficacy to improve vision. In order for it to be effective, it must be started within the 6 hours of symptoms onset. Treatment options here include the use of vasodilators, lowering the intraocular pressure by doing ocular massage, or giving intravenous mannitol. We could also have the option of reducing the retinal edema with IV methylprednisolone or giving thrombolytic therapy. Surgical treatment may be done if indicated by doing anterior chamber paracentesis. Thank you.
My name is Gloria Grace with last 3 digit number 162, and I'm going to explain about the treatment of retinal vein occlusion. So central retinal vein occlusion has various treatment options. The aim is to mitigate sequelae that might be happen, including macular edema and anterior segment, and retinal neovascularization. So first is panretinal photocoagulation. This therapy could prevent or treat the development of ocular neovascularization and neovascular glaucoma, also the blinding complication associated with it. Furthermore, it can prevent the hemorrhage of vitreous. The second option is anti-VEGF. Two of anti-VEGF that are effective to use are ranibizumab, which could improve anatomic and functional capacity, and intravitreal aflibercept that able to treat macular edema secondary to RVO. Next one is corticosteroid. The mechanism of action is to reduce capillary permeability in macular edema. And the last one is surgical intervention, such as vitrectomy and radial optic neurotomy. To determine which choice of treatment that should be done for the patient, detailed medical history, physical examination, and laboratory tests should be done appropriately. So that's all from me. The next slide will be presented by my friend. Thank you.
Hello, my name is Luh Wina Saraswati with last 3 digits of student ID number 142. Now I will explain chapter 3 conclusion. Retinal artery occlusion or retinal vein occlusion is an obstruction of retinal artery or retinal vein which can cause retinal hyperperfusion, gradual cellular damage, vision loss, and disturbance in processing visual input. In central retinal artery occlusion, the incidence was 1.4 times more common in men than in women, while retinal vein occlusion was the second most common retinal vascular condition after diabetic retinopathy. Retinal artery occlusion and retinal vein occlusion are classified according to the location of the blockage into central and branch. Risk factors for central retinal artery occlusion are associated with being more than 50 years old, being male, and having other coexisting systemic disease, whereas retinal vein occlusion usually occurs in older people with risk factors such as smoking and several other systemic diseases. Retinal artery occlusion is caused by a sudden cessation of blood flow to the eye caused by various underlying disorder, for example, blockage due to embolism. Retinal vein occlusion has various etiologies, one of which is arteriosclerosis. Clinical manifestation in patients with central retinal artery occlusion and central retinal vein occlusion tend to be almost the same, including blurred vision and massive vision loss. In retinal vein occlusion, ophthalmoscopy findings include cotton spot, retinal nerve fiber layer damage, and swelling of the optic nerve. While in retinal artery occlusion, ophthalmoscopy findings called cherry red spot on the macula lutea. The diagnosis of retinal artery occlusion is based on clinical support with initial laboratory examination, fundoscopic examination, fluorescent angiography. While in retinal vein occlusion, the diagnosis is made based on clinical observation of the eye and supported by laboratory tests. There are several option treatment for central retinal artery occlusion, including the use of vasodilators, eye massage or giving intravenous mannitol, intravenous methylprednisolone, and thrombolytic therapy. While there are several treatments for central retinal vein occlusion, including photocoagulation, corticosteroid, antivascular endothelial growth factor, and surgical treatment. That's all from me. Thank you.
Now we can see this is our references that we use for this student project. Alright, and here comes to the end. Thank you for your attention for this student project. Sorry if we have many mistakes. Om Santi 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 Om. Goodbye.